Good evening, everybody, and thanks for joining us for the launch of the Framework for Early Recognition of Córdoba Syndrome for Primary Care Clinicians. Tonight should be a really interesting evening. Just as starting off with some housekeeping, I'm going to pass over to my colleague Neil Cheverton, who is the BAS Policy and NICE Liaison Officer. My name is Diarmuid Ferguson. I'm the chair of the National Back Pain Clinical Network, and we'll be just discussing Córdoba in primary care tonight, and tonight's focus is on secondary care. I'm going to pass over to Neil, who will just do some housekeeping.
So good evening, ladies and gentlemen, and welcome to the first of two consecutive evening webinar launch sessions for the Primary Care Córdoba Syndrome Framework. As Dermot's just said, this evening's session is targeted largely at the secondary care environment, and it's my pleasure to be here this evening to represent BAS and its support for the framework. So firstly, on behalf of Dermot, Elaine, Sachin and all those involved in organising this event and our speakers, I must thank all the attendees for their interest in the framework. It's great that all 500 places for this evening's event have been taken, as have another 500 for tomorrow's webinar, which is aimed more at a primary care setting. It's been quite a long journey to get to this point, and I first became involved over a year ago in my capacity as the BAS Executive Member for Guidelines. At this time, much of the groundwork for the development of the framework had already been done by Elaine, Dermot and the National Back Pain Pathway Clinical Network. Following a well-attended and successful multidisciplinary consensus meeting at King's College Hospital in December last year, a draft final framework document was produced, and it was anticipated that this would have been presented at the BritSpine meeting, which was planned for April in Glasgow. But due to the cancellation of this meeting, we didn't feel it was reasonable to delay the presentation of the framework until the next BritSpine meeting can take place. Hence these dedicated webinar release events. I think you've all had the opportunity to review the framework which was released this morning, and there'll be opportunity to ask further questions following this evening's presentations and during the presentations. Going forward, there'll be a 4-week final consultation period before release of the final version. Both BAS and the National Back Pain Pathway encourage you all to consider how best the framework will fit into your local network pathways. So enjoy the evening, and please feel free to put questions to the panelists throughout and at the end, and I'll hand back to Dermot who'll detail the events of the webinar in more detail for you. Thank you.
Thanks a million, Neil. And again, I'd like to thank the support of BAS, who've been great in facilitating tonight's webinar and allowed us to launch to all our surgical and other colleagues. Sachin, the president of BAS, is sitting in the background, and he's moderating this evening, and he will be fielding the questions with his team there. Okay, so tonight, what we're going to do is we'll initially want to find out who's in the room. So I'm going to ask Henry if he can just bring up the first poll, and we'd just like to know what is your profession. Obviously there's quite a number of people who are involved in Córdoba and in back pain, whether that be in primary care, secondary care, or even in the independent sector. So we'll just give you 20-30 seconds to vote, and then we can bring up and see who's there. I know there was great interest, and the number of spots were sold out in 3 days actually, which led us to have another night tomorrow night. The results shouldn't take long. Have you got that one, Henry? Does that come through? Some FCPs, osteopaths, physios, and spinal consultants, trainees, and others. So next question I'd like to ask is, where do you work? Are you based in primary care, in secondary care? Are you in an interface clinic sitting in between primary and secondary care? Or do you work in A&E? Is that A&E in a district general hospital, or are you looking to be based in a specialist spinal service or other? Again, this gives us an idea of the experience in the room, of some insight to help us understand where you're coming from so we can help you. So good split there of 40% in primary care, quite a few, about a third in MSK interface services, 3% A&E, 7% district hospitals, and 17% in specialist spinal services. Next question. We just want to see what's your understanding of how your local chord equina pathway works. Is it a case of the referral is made via the GP? Do you refer direct A&E? Do you refer direct orthopedics? Or do you have the ability to refer direct through to a spinal service? If there's another pathway or avenue that you use, just let us know and press on the other there. We do know there's quite a lot of variance around the country, and one of the reasons for having a framework such as this is to get an idea of what's going on and to see if we can push best practice. And we will discuss that further in the session. Quite an interesting one here. I'd just like you to actually rate the pathway. What's been your experience of it, of your local pathway? Have you found it great, or some difficulties on that? I know that I'm quite lucky. We've done quite a lot of work in our area, and thankfully it works quite well. A lot of collaboration and cooperation amongst lots of professionals have led to that, and it is a case of it is something that we would all strive towards. So just on that, actually, yeah, so not bad, pretty good, and excellent in some. Okay, so that's a good reflection. And final question is, just what's your general confidence in managing chord equina currently? So not confident at all, you're unsure what chord equina is, or that you're fairly confident in a tricky Friday afternoon, you would know what to do and would be able to do all the right things. So we'll just see what people say on that. And again, some reasonable confidence in its management. Good. That all makes sense. So what we'd like as well, obviously we've taken a poll there of what's going on. There will also be some feedback. We'd like some feedback at the end of the session, so we can understand what you've learned, and also be space for you to give feedback on the framework itself, and that'll be open for a month. So the format of this evening, we have a number of excellent speakers. They each will speak for between 5 to 8 minutes. Apart from the initial one, Elaine's going to speak a little bit longer because she's presenting the pathway. Following that, there'll be a couple of questions, and then we'll transition to the next speaker. And then at the end, we're hoping to have a good discussion. Questions can be sent to Sachin throughout the evening. But start putting those questions in now so that we can start responding. We hope to be finished and all tidied up in 90 minutes. And the framework itself, as I said, you should have received a copy, but it will be published on Friday. The reason it's on Friday is we're doing another launch tomorrow night. So what I'd like to do now is to pass over to Elaine. Before I do that, I'm just going to go through our speakers. Elaine Buchanan is a consultant physio, and she was the founding member of the National Back Pain Clinical Network and instigated the development of the National Back Pain Pathway and Radicular Pathway, and been involved in back pain for some time now. the main purpose of the network is to implement the national pathway, to actually promote good practice across the UK. How that practice is put into position is obviously decided locally, but this is a pathway that can fit into your local region. She will be discussing and introducing the framework. Then we'll move on to Chris Mercer, consultant physio, and he'll give a perspective from AHP and FCP, first contact practitioner. He's been doing a lot of work on that. I'll let him expand on that. Jerry Murrow is GP, and he is medical director at Clarity, and he does the clinical knowledge summaries for NICE, and will be useful and be able to give their contribution and view on this evening's events. Daniel Horner is a professor in emergency medicine and critical care, and he wants to give that emergency care perspective. I think it's a case of we all tend to sit in our own little bubbles of trying to manage this very, very difficult condition, which can be devastating for patients. But I know from personal experience, it's devastating for clinicians who are involved in these cases too. Patrick Stratham will finish up, and he'll give the surgical view, and Patrick's the chair of UKSSB. So on that note, enough speak from myself. I'm going to pass over to Elaine, who will introduce the framework. You there, Elaine?
Thank you, Dermot. Hello, everyone. Thank you for joining us tonight. By way of background, I'm the consultant physiotherapist at the Oxford Surgical Unit in Oxford, and I'm also the editor of the National Back and Radicular Pain Pathway. I have 26 specific years of experience in spinal pain, and I have sadly seen many people with who have been unfortunate enough to get Cauda-Equina syndrome in my time. It's always been a desire to try and improve things for the pathway there. Next slide, please. There we go. An important part of the NHS England Improving Spinal Care project was the development of the National Back and Radicular Pain Pathway. Following on from this, the National Back Pain Clinical Network was founded in 2017, and the aim was to promote the implementation and advancement of the pathway. The National Back Pain Clinical Network has always been closely associated with the UK Spine Societies Board and is now one of the constituent societies. BAS have certainly led the way in developing the standards of care for the investigation and management of Cauda-Equina syndrome in secondary care. At Brit Spine in 2018, the National Back Pain Pathway Clinical Network contributed to a really successful session where the house was full and overflowing. The Cauda-Equina syndrome was the topic of that session. And then in 2019, Connect Health published their white paper on Cauda-Equina syndrome in response to a muddy medical legal water related to bilateral leg pain as a red flag for Cauda-Equina syndrome. It was clear that there was a growing need that has been unmet for a guidance to be developed for primary care related to the management of suspected Cauda-Equina syndrome. Next slide, please. So in response to this problem, the National Back Pain Pathway Clinical Network set up a working group, predominantly from the committee members, but with a few other invited people, and had their first meeting back in June of 2019. There has been lots and lots of emails, teleconferences, and many, many drafts of the document to get to where we are now. We are very grateful to all that have contributed to what is a truly multi-professional document, and that's not something we've generally seen before. We hope that this document will enhance the early identification and emergency referral for people with symptoms and signs of Cauda-Equina syndrome. Next slide, please. Tonight, the National Back Pain Clinical Network is really proud to launch their framework for early recognition of Cauda-Equina syndrome. I very much hope you've all had time to read this copy and had time to digest it. The framework is for primary care clinicians and for MSK interface services to use to shape their local policies and procedures and pathways. And if you can influence it at regional level, that would be also extremely good. Obviously, this document will need tailored. So although we've put it forward as a framework, it won't fit every environment. And what you need to do is take the document and tailor it to the environment that you work in. It provides us guidance on clinical identification of signs and symptoms that may be suggestive of Cauda-Equina syndrome, but we know that individually these signs and symptoms are not particularly good, and that's why it's really been promoted that it's a combination of signs and symptoms that we need to be working towards. The guidance focuses on differential diagnosis to take into consideration, safety netting, and emergency referral where signs and symptoms indicate that the person might be at higher risk of acute Cauda-Equina syndrome. There's an emphasis on communication, documentation, and the time-sensitive nature which requires emergency escalation with this condition. Next slide, please. Themes of feedback were identified from all these emails and teleconferences and the conference that we had in December. And they've shaped the final version that's come out tonight. I'm sure it's no surprise to you that the two strongest themes were anal sphincter examination and bilateral leg pain. Next slide, please. The problem is that anal tone testing on its own is not a good test. The evidence is high risk of bias because of the low quality. There's lots of retrospective studies of small samples, really in hospital settings. There are no studies that we know of in primary care environments, and there's no control of testing procedure or the inter-tester reliability. Reported anal tone tends to have higher specificity but very poor sensitivity. That really means that in a hospital setting, anal tone is better at ruling out Cauda-Equina syndrome than ruling it in. And we have to expect that it will have a very high false positive rate. There are no studies that I've come across that look at voluntary anal contraction, and we generally think that the contraction is probably a more useful test, but all the studies are really talking about anal tone. And we do not yet know enough about the clinical utility of co-binding tests, and that's something that certainly shows promise. But for primary care, the prevalence of Cauda-Equina syndrome is very low. It's around 0.04%. Although not difficult to test, anal tone is something that a good physiotherapist is perfectly capable of doing, but they might never have done it before, and it's not something they're going to do very frequently. So when you have a patient in front of you, it's a bit of a difficult thing to start doing when you've never tested before. There are also many lone clinicians. They work on their own, not just within physiotherapy, with osteopathy and chiropractic practices. And in those environments, there's no chaperone available. The majority of primary care and MSK interface clinicians do not have specific spinal experience, and that limits the interpretation of the findings. Now, obviously, if you're in an environment where you do have a lot of spinal experience, if your practice feels that that is something that can be offered, then obviously, as long as you've got the good clinical reasoning skills, your pathway might be different than what we've put forward. But by far the majority of primary care clinicians, this is not a test that is useful, and it's not a test that can easily be implemented in primary care. So there's very varied views about the usefulness of anal tone testing in a hospital setting, but that's out of the scope of this framework. This framework is about primary care. Next slide, please. Bilateral leg pain is a problem because it's not very well defined. So a lot of the guidance talks about bilateral leg pain rather than bilateral radicular pain. And the CONNECT problem, when they wrote the white paper, did identify that if we send every single patient with pain in both legs to a hospital because they're concerned about cauda equina syndrome, it would be a tsunami. There would be an awful lot of patients out there. So the experience of the National Back Pain Clinical Network Committee was that there are lots of people in primary care who have bilateral leg pain that might even look like it's radicular. There's many people who also have severe unilateral sciatica, and those people often have pain in the opposite legs for lots of other associated reasons, but not because they have compression of the opposite nerve root. Again, the evidence is weak around bilateral leg pain, and there's a very high risk of bias. In isolation, this is clearly not a good test. Dion, when they looked at their systematic review, they pooled the evidence, and they estimate the sensitivity to be about 0.43 and the specificity to be about 0.66. Again, it's a test with high risk of bias due to low quality. The evidence so far is all based in secondary and tertiary care, and we don't really know the prevalence of bilateral radicular pain in primary care. So there might be moderate specificity, but very poor sensitivity, and not even a good not even as good a diagnostic test as anal tone. We did emphasize that it's more helpful to identify bilateral pain in a radicular pattern, and agreed that the pathway would follow on these three clinical scenarios. The acute and progressive with signs, other signs of cauda equina syndrome should definitely be following the emergency pathway. Those where they've got bilateral radicular pain with some myotomal weakness or dermatomal sensory loss, they might follow more of an urgent spinal pathway, and people with normal neurology and no other cauda equina syndromes, you would follow the National Back and Radicular Pain Pathway. Next slide, please. The National Back Pain Clinical Network experience of developing this framework has been very positive, and we feel that it's paved the way for our society and the other societies of the UK Spine Societies Board to work together to develop future collaborative initiatives. The next step for this pathway is to join up the cauda equina syndrome pathways across the system, because now we've got a primary care pathway, we've got a secondary care pathway. There isn't really a good pathway around emergency medicine, and we need to look at what the general practice is also doing, but we need a real end-to-end pathway developed for this problem. We would very much encourage NICE to get involved with endorsing this document, and the NHS England to get sign off with it, and we're hoping to do that through the regional spinal networks as well. Next slide, please. We very much hope that the implementation of this framework will contribute to reducing the numbers of people who live with symptoms of persisting cauda equina syndrome. We must always remember that this condition has a devastating effect on personal and social lives, many of whom are actually young to middle-aged people who were in work prior to this onset. It's really a very bad condition. Thank you for listening. Next slide.
Thanks, Elaine. That was a good introduction to the pathway and what the effort that's gone in from all parties, right? And thanks to the Back Pain Clinical Network to take the lead to set this up from a primary care perspective. But as you rightly said, there is that willingness, because I speak from a surgical point of view. With PASS SPNS, the document that is available for secondary care. But I think that's the point we want to do, is try to get a seamless transition from primary care to secondary care. And I know there is work going on at the other end to take management of patients who've got cauda equina, who've had treatment from a rehab point of view, so that, you know, you can see the full spectrum from start to finish to give the right care, because as you say, rightly say, this is a devastating condition. So the one point I would like to raise, I know there is a keen interest to get NHSE to endorse it, but please don't forget, we've got members from all devolved nations. So yes, NHSE endorsement would be very helpful, because I know the devolved nation will look to that document. NICE would be a good one, but if it's co-badged by all the societies, I think from a Welsh perspective, Scottish perspective, Northern Irish perspective, like I'm from Wales, I'm in Wales, so I would not, I think I would prefer it to be badged everywhere. So this can be rolled out to all the patients. Any pressing questions, Rohit, Rajat, please?
Yes, there is. Good evening. So this is from James Mitchley. He says, does the framework aim to accommodate female sexual dysfunction or male priapism in the identify section?
Elaine, do you want to take that, please?
So the framework doesn't specifically address that. And my thoughts is that these are symptoms that tend to be not necessarily used for the identification of cauda equina syndrome, but if the patient reported it, you would take account of that because it's still sexual dysfunction. But there's symptoms that sometimes appear later rather than earlier. And it's really about when people have symptoms after they've been treated, after surgery, then they become really, really important, and obviously an important thing for the appropriate referrals for help and advice to be made with regard to that. But the objective of this framework is to get people before their symptoms have developed to that stage.
I think, Elaine, what you presented is quite pertinent. So I think, Rajat, you've got one more question to ask from the panel.
Yeah, I can put this forward. It's from Mike Grevitt. It's about bladder scan. So what is the panel's view of the use of bladder scan post-void residual volume when it's greater than 200 mils prior to discharge of a suspected cauda equina syndrome?
Do you want me to take that one?
Yeah, please, Elaine.
Yeah, so the bladder scans are not really available to the majority of primary care clinicians. So that would be something that would be used when the patient enters secondary care. So obviously our current evidence is supporting that if the volume is greater than 200 mils, that would be something that would be strongly suggestive that the person might be developing retention or in retention, and that would worsen their prognosis. What we're trying to do with this framework is actually get people at the suspected stage and get them before they've actually developed urinary retention. And, you know, unless primary care invests a lot in bladder scans, it won't actually help us determine who needs to be referred to an emergency spinal service. Okay,
I think, thanks, Elaine. So I think we should get to the next speaker. Chris Mercer, as Dermot introduced, is a consultant physiotherapist and would give a perspective from the first contact practitioner point of view in a primary care setting. So Chris, over to you, please.
Thanks very much, Sachin, and for Dermot and the team for inviting me to speak. Just move on to the next slide, Dermot, please. So I've been asked to look at it from a primary care, physiotherapy and FCP perspective. And I thought really there are two challenges for us on the front line, if you like. One of those is around the diagnostic challenge, which Elaine has touched on, I'll talk a little bit about. And one is around the workforce challenge. And there are significant changes in the workforce, as a lot of you know who are on the webinar tonight, looking at the stats of where people come from. So in terms of the diagnostic challenge, we used to think this was an easy an easy thing to diagnose. Elaine's outlined that clearly it isn't. We used to think it was really, really rare. Elaine's outlined from some of the data from this paper, the Huritz-Aus paper et al., around 0.8% of low back pain in primary care presenting as cauda-equina, about 0.27% in secondary care. But I think this is an underestimation. If we look at our practice in physiotherapy and in first contact physiotherapy or direct access physiotherapy, it's a very different experience. And the questions around cauda-equina are significantly more than these percentages. What we don't have is the evidence to support that, and there's some work ongoing nationally at the moment to try and establish the instance within primary care physiotherapy clinics. So I think we might get a very different picture, but still it's a rare condition. We know that diagnostically it's a challenge because people presenting with supposedly clear signs and symptoms of cauda-equina syndrome, very few or only a very small percentage of those end up with clinical and radiological cauda-equina. So around the somewhere between 15 and 19%. So there's a diagnostic challenge in us being more nuanced in our approach to managing these patients and more skilled at managing these patients. So I think that some of the emerging evidence from Patrick Statham, who we'll hear from later, and his team, looking at understanding cauda-equina and how we manage it, might help us in that stratifying those patients. Next slide, please. But for us, particularly as a physiotherapy profession, but I'd include osteopaths and chiropractors, there are clear challenges for us in terms of competence and skills to be able to assess these patients fully and appropriately, and to consider differential diagnoses. We know that the vast majority of patients with bladder issues won't have cauda-equina. There are a whole host of other differential diagnoses that we need to consider. Similarly with bowel problems and sexual dysfunction. The vast majority of the causes of those problems are definitely not cauda-equina related. So we need to try and unpick that. And in order for us to be able to do that, we need to be working at a high level of skill with recognised competence. And these frameworks that you see on the screen here have been rolled out over the last couple, 2 or 3 years, and I'm sure you'll all be aware of these. But what these lay out is a very clear standard for us to aspire to and for us to reach. And I think what this gives us as first-line clinicians is confidence in our own skills. But what it should also do is give the system confidence in our skills at the front end. And when I'm talking about the system, I'm talking about people further down the line. So that could be our A&E colleagues who we're referring on to, or the spinal surgeons, depending on what your pathway is. But these are all M-level qualifications with clear competence and guidance behind them. So this is really where I think those clinicians not working within the NHS or not working in FCP or defined AP roles could look to these frameworks as support to develop their educational and competency frameworks. So some of the chiropractic and osteopathic colleagues or people working in private practice, either on their own or within in the independent sector, can look at these documents and hopefully help to align some of the training and competencies that are required for us to undertake the right examination and the right differential diagnosis. Next slide, please. Can you do the next slide, please, David? Thank you. I think one of the key thing in our primary care setting is managing some of the uncertainty. So one of the questions was around managing emerging or more vague symptoms. We know that safety netting is absolutely key for these patients. And for those patients who are incontinent, that's very easy. For those patients who have complete numbness around their saddle region, that's easy. But it's often not like that. It's a very, very grey area. So patients need to know what to look out for and what to do in a timely manner. So you'll all have seen these cards. These are freely available through the MATP website and through various other means, but they're also available in now, I think, 33 languages. So these are really important for us to be able to communicate clearly with patients if there's any diagnostic uncertainty. So if we have any other confounding comorbidities, this is how we can manage it. And it's a really nice way for us to be able to manage it in primary care. I think one of the questions also asks about telephone triage. And obviously, you know, in these times of COVID and probably moving forward into the future, there'll be a much higher rate of telephone consultation and telephone triage. So, you know, the diagnosis of cauda equina is predominantly based on the subjective history taking. And we can ask some of these questions over the phone, no problem. We can do these by video consultation, but we can still safety net the patient over the phone. So I think it's really important for us in primary care that even though the way we work has changed, we still need to maintain those same standards. Next slide. So why the need for this pathway in primary care? Well, unfortunately, we know that the pathways that we currently use aren't successful. We know from the VIAS study, the ENTICE study, somewhere around 60%, just under 60% of the patients that are referred for spinal surgical opinion relating to cauda equina arrive without having had an MRI scan done. You know, there's clearly an issue there. That can't be the right pathway. MRI is a diagnostic tool for this. Following clinical examination, and 60% of patients are arriving without having had a scan done. Well, that there's clearly a failure there of the system. And for us in primary care, managing these patients, part of that problem is access to MRI scan. And I think Dan's going to talk about that later. And a lot of these patients, about 60% again, were referred out of hours. So for us working in FCP land, that's not going to touch us. So some of those patients are coming in through the emergency system and then being referred on. So there are big system issues that are going to hinder us in our diagnostic acuity and the access to diagnostics. Elaine's touched on digital rectal examination, so I'm not going to go there other than to say it's been a big bugbear. We've talked about this for many years, about the sensitivity and specificity of this as an examination. And it's also an issue for us in primary care in terms of chaperoning. This was something that came up at the December meeting, and it was a surprise to, particularly I think to secondary care colleagues, that there are times when chaperones aren't available. So what do we do then? If this is a required examination, then clearly we would need chaperone. For most of us working in GP practices, there should be access to a chaperone, no problem. But if you're a sole practitioner, physiotherapist, chiropractor or osteopath, and you have someone with suspected cauda equina, do you do this examination or not? Well, I think hopefully this pathway will have covered that off, and Elaine was very clear about this is not a test that we're recommending in primary care. So I think that's a big step forward. I think the issues around secondary care will need to be resolved at a later date, but for primary care this has been really important. So I think really for me the kind of brief overview of our responsibilities in FCP land is around our competencies and training, and I think there's that reassurance going forward, and I think with the rollout of further FCP roles across the country, we can be assured that there will be musculoskeletal expertise at the front end to support current GP colleagues who do have musculoskeletal skills and interest to manage this patient cohort. Thank you.
Sorry, Sachin, you're on mute. There are a couple of questions.
Sorry, yeah.
One from Christian van der Merwe. Basically, Chris has addressed part of it about around telephone consultations and recommending whether a physical examination is integral for fully assessing and referring patients with suspected CES.
Yep.
And then he goes on to ask,
I'm happy to take that.
Would this represent an unacceptable time delay?
No, I don't think so. I think in terms of in terms of the clinical diagnosis, it is predominantly based on the subjective history. We've talked about anal tone testing as a not being necessary. Some of Michelle Angus's work is suggesting that there may be some benefit in sensory testing as an early identifier of impending chordal equina. Obviously, if patients on the end of the phone, we can't do the test, but there's no problem with us asking the patient to do that test themselves, so we can explain. But the requirement from the FCP role at the end of the phone is that you're explicit about why you're asking the questions. So we need to actually set those questions up, or set up the reason why we're asking the patient to test their saddle sensation. So we need to be absolutely explicit that this is part of a safety check. Seek their permission for that. If they're not happy to do it, then fine. If they're able to do it and identify that they have some saddle sensory loss, that may add to the picture. But our responsibility from a telephone triage for somebody with back pain, with chordal equina, with some bladder or bowel disturbance or sexual function, our responsibility is to get them to the next level so that they can be investigated urgently. So I think if you're not able to do a physical examination, that's fine, but we need to get them to somebody who can do that physical examination and arrange the necessary imaging.
Thank you, Chris. Sachin?
Yeah, no, okay, great. Jerry, so next person to speak is Jerry Marrow, who's the Medical Director of Clarity Informatics, and he is with the Clinical Knowledge Summary with NICE, and he's GP by background. Jerry, so please present your perspective of things from the framework point of view, please.
Thank you, Sachin, and thank you for the invitation to speak this evening. If I could have the next slide, please. So for those of you who don't know what clinical knowledge summaries are, it's part of the NICE evidence suite. It's written by Clarity and our authors, but it's clinically and editorially independent from NICE. It covers 370 or so primary care topics, and amazingly, almost 500,000 people, unique individuals, look at this every single month in the UK alone. It's also NICE accredited, so it covers a great deal of primary care in terms of presentations either by disease or by symptom, and that's how it works. Next slide, please. So on chorda equina specifically, it is part of our sciatica topic, and that's how it's structured currently. I won't go through the current content, but that's how it's set out. It's designed to be a sort of point of care tool, so people can refer to it either before, during, or after a consultation, and that's how it's presented. It's designed to be question and answer, so clinical scenarios: how do I manage, how do I treat, how do I investigate a patient with X, and that's how it's designed. Next slide, please. So we have a team of GPs and pharmacists who write the content. As I said, it's independent editorially from NICE. It works on using a process of evidence evaluation and takes the hierarchy of evidence approach. And there is a clear direct link, for those of you who've looked at the website, from evidence to recommendations, so that when you see a recommendation that's saying you should be doing this, or you should consider doing this, there's a direct link then that takes you to why we've said that. We also use a large panel of about 3,000 external reviewers, who are everyone from the NICE clinical development group, guideline development group, to experts in the field who've written extensively about particular topics. We've also involved lay readers and users who give us advice on where we're presenting information for patients or carers, and also stakeholders such as yourselves and indemnity providers that take a keen interest in making sure that what we're saying is relevant to them and speaks to the priorities that you have. And so what we do is we do a horizon scanning process, which is every week, and we look at hundreds of sources from high quality accredited sources, usually RCTs and guidelines, but we do occasionally use things like expert view rather than just published evidence. We try not to use that if we possibly can, unless there really is no evidence around. And then every week we update NICE with what we've done differently, and we provide them with that, and they publish based on that. We also create 7 or 8 new topics every single year, and that is usually in discussion with NICE about what they feel the priorities are. We provide a sort of list of things we think we could do. They come up with a list, and sometimes we triangulate with other experts as well, the Royal Colleges, and then we come up with a sort of wish list of what we're going to do next. And that, in a nutshell, is what I do as a day job. Be delighted to take any questions.
Terry, that's very helpful to get an insight. That we would like to get endorsement from NICE. So I just wonder, with your experience, if like you can see the amount of effort everybody's put in, how can we be help CKS in the process as a society? From I'm just talking about the Back Pain Clinical Network and BATS and UKSSB for that matter.
Well, now that we know, well, once you've finally got this published, obviously we'll be very much alive to that publication date. We'll take that information, we'll incorporate it into an update of the topic. And what we'd then do, if we felt there was some variance elsewhere, we would sense check that with you. So we'd say, this is what we're now presenting. We're going to publish this to NICE next month. And we could, if you nominate individuals who are keen to oversee that, we could send that out to them and get them to sense check it, make sure that aligns precisely with what you're trying to say. Given, as you say, I think all the speakers have said so far, depending on clinical pathways that are available locally, and we usually make that clear that not all places, regions have the same pathways, but so we allow a little bit of flexibility. But given the audience is going to be, as I say, almost 500,000 people, I think we'd be keen to get that as a vehicle for you to use that so that people are actually seeing it in front of them, but it represents what you're trying to say within the evidence base.
That's great, Jerry. Thank you. So we're nearly more than halfway through, so I think we've got plenty of questions to go through as well. So next is Professor Daniel Horner. He's based up in Manchester or Salford, I think, and he's an emergency care consultant. So we'll get a perspective from an emergency care point of view. Dan, over to you, please.
Thank you for the introduction. Good evening, everyone. Thanks for the invite to the launch, and congratulations to those of you who are involved in developing this pathway, which I'm sure will improve patient care. I've been asked to just put together a few slides to summarise the challenges of CES diagnosis in secondary care and how this pathway can help. I think there's lots of similarities with challenges between primary and secondary care in terms of diagnostics. So a lot of this will be reiterating previous messages. If we can have the next slide, Pete. So this is a visual representation of the haystack of atraumatic back pain. And cauda-equina syndrome is, of course, one of the needles. I mean, the other ones that terrify us in secondary care are hematological malignancy and metastatic disease, which we worry about. But of course, they're rare diagnoses. So back pain accounts for about 3% of our attendances to emergency departments, and cauda-equina syndrome, according to recent college documentation, has an incidence in that population of somewhere between 1 and 2 per 100,000 people. So what does that mean in context? At Salford, we see about 3,000 patients a year with atraumatic back pain. We tend to perform MRI imaging to exclude cauda-equina syndrome in about 10% of those, so 1 to 2 a day. We have a 12% pickup rate of around 1 to 2 patients per month. Therefore, of the people who come to Salford Emergency Department with atraumatic back pain, 99% of people won't have cauda-equina syndrome. And this is the first challenge, really, isn't it, with atraumatic back pain in secondary care, is that it's a rare disease with a low prevalence. And so rotating trainees that go through emergency departments for 6-month periods only and don't develop any expertise in this condition are unlikely to see it, and they are far more likely to see musculoskeletal back pain and other presenting conditions. So it can get overlooked. If we have the next slide, please, Amit. So the second issue is that it's hard to refine how we approach the diagnostic tests for a suspected cauda-equina syndrome, because We usually work in the emergency department on probability and risk. So we will take a history, we'll perform an examination, we'll perhaps do some blood tests, some x-rays, some non-invasive tests to try and change the probability and the post-test probability, especially of whether someone is likely to have a more serious condition or not. But we've already heard from the previous speakers that a lot of the classic aspects of clinical examination are not particularly reliable, not sensitive or specific for the diagnosis of chordoaquina syndrome. And we don't have much in the way of non-invasive testing that can contribute to accurate diagnosis. We know from Michelle's work as well that decision rules even don't particularly help, and we like those in emergency medicine. So we're left in a difficult situation of not really being able to refine in any great detail this cohort of patients as to who should proceed to imaging and how urgently. So perhaps we should scan everyone just to make sure. Well, Elaine mentioned earlier the tsunami that would create in terms of patients arriving to the department. And of course, it causes real individual risk to patients if we're going to perform additional diagnostic tests and imaging that may cause delays in hospital admission. Then we're talking about risks with venous thromboembolic disease from patients lying in hospital beds, nosocomial infection, delirium, etc., etc. And also, the more you image, the more you find. Incidental findings cause a lot of other problems with diagnostic approaches to rare disease. So there is particular patient risks with that. And if you move on slide-wise then, please. And then there's not just a patient risk, there's a system consequences to increasing the amount of investigations and traffic through emergency departments. And the more people that attend the emergency department for diagnostic tests, the more crowded it becomes. The more crowded it gets, the more dangerous your emergency department becomes, unfortunately. And there's a variety of reasons behind that. Some of them are direct risk to patients from nosocomial infection again, and sitting next to people with transmissible respiratory illness, but other distractions and increasing frequency of questioning and high patient to low clinician ratios all account for misdiagnosis, for haste, urgency, complications, and there's quite a strong body of evidence now to suggest that crowding has a direct effect on mortality. So that's a real system risk of over-investigating these patients in emergency departments. We can move to the next slide, please. The pandemic, of course, has pushed this forward recently. So this is just one example of an organisation that has taken the approach of redirection from emergency care or use of other services to try and redirect patients who may be able to have diagnostic tests in a different forum that perhaps will be safer for them and safer for other hospital patients in general. And not only has the pandemic pushed us towards this for clear infection control reasons, but there's been a long move for the last decade really towards ambulatory care and what we're terming now as same-day emergency care. We have validated pathways for pulmonary embolism, for deep vein thrombosis, renal colic, transient ischemic attacks, lots of potentially very serious conditions that we recognise don't necessarily warrant an actual attendance at the emergency department. What they require is urgent expedited diagnostic testing in some way aligned with secondary care. And a lot of those presentations now are streamlined away from emergency medicine in order that people who have the expertise, such as primary care clinicians and musculoskeletal practitioners, can direct these patients to the appropriate type of investigation. And it can then be picked up and acted on. Our spinal physiotherapy service at Salford is a shining example of this. So our community physios and primary care interface has direct liaison to a spinal physiotherapy team at Salford, and if there is suspected chordoaquina in some of these patients, often they will be discussed, referred, imaged without even hitting the emergency department at all. And that's better for the patient and better for the system, because then everyone with the relevant expertise has guided that patient through their journey. If we just move to the next slide. There's lots of guidance now, and this pathway is very welcome. In addition to the GIRFT conclusions from the previous Getting It Right First Time report, the SBSS pathway, we have NICE guidance, and there's this position statement from the Royal College of Emergency Medicine. And everyone in these pathways is focused on the composite of red flags and the referral pathways to facilitate imaging. And that's entirely appropriate, and we all need to be doing what we can for that. But I suppose I would finish by just saying that what we don't really want is patients sitting next to those with respiratory illness or other potential transmissible infections in an emergency department, waiting to see a junior clinician with no expertise in in musculoskeletal conditions. You know, what we want is a streamlined service that gets these patients imaged appropriately when there is suspicion or risk of cauda-equina syndrome. And then the pathway facilitates ongoing liaison with specialist secondary care services to get the patients the right care that they need in a timely fashion. I will finish there and happy to take any questions now or questions.
Great, Dan, thank you. That's very helpful. Just whilst Patrick puts his slides up, a quick one is about the delays in imaging and the barriers to that from your point of view. Okay, as you mentioned in Salford, the FCPs and the MSK physios have got direct access to radiology, but the ones who go through emergency care, medicine department, how is your experience on that?
So I think it's very challenging, and it depends on the centre. I think, you know, the college is trying to move emergency medicine away from this, really. I mean, obviously there's a huge role to be played out of hours, but in hours, I think they're moving towards redirection towards specialist teams such as orthopaedic surgery, because we know that these patients need to see an expert and have the right imaging facilitated. And I suppose, you know, all of us can say within the next couple of weeks that we are likely to see someone and think about whether they have cauda-equina syndrome. And if we do, when we do, how are we going to access MR imaging for them? You know, my advice about that, I suppose, would be to have those conversations now rather than at the time, so that you can facilitate the best pathway for your patient. And often radiologists and other stakeholders will see the benefits of expedited pathways when you point out the lack of attendance in secondary care, the lack of overnight bed stays, the lack of delayed in diagnosis when you have a specialist communicating with the radiologist firsthand, rather than a relayed message through a junior clinician in an emergency department. So lots of ways that you can have the conversation and take it forwards. Okay,
that's great. Thanks, Dan. Next but not the least is Patrick Statham. Patrick's a consultant neurosurgeon based in Edinburgh, and he's the current chair of UKSSP. And Patrick's done a lot of work on cauda-equina syndrome, and I think it's befitting that he's going to talk about cauda-equina syndrome from a secondary care perspective. Thanks, Patrick.
Great, thanks for inviting me to speak. And I'm going to come to really the point that Dan's just made once I get to the end of this 7 minutes. My background is working as a neurosurgeon in Edinburgh for the last 30 years. But since the advent of MR in regional centres in the early 1990s, we've been trying to find the quickest way to get patients with acute compressive cauda-equina syndrome to urgent surgery, differentiating this minority from the many with shared common symptoms such as back pain, sciatica, and urinary incontinence has been a big challenge. And on one hand, the answer is simple and obvious: get an urgent MR scan as locally and as quickly as possible, and particularly now that MR scans are much more readily available in district general hospitals. But the problem with throwing that net out so wide is really the logistics. How do we all manage those patients quickly and safely? And I think these guidelines help enormously to liberalize, but also rationalize those patients that need that urgent scan. MR is undoubtedly the single most useful investigation in a patient with rapidly evolving, potentially harmful spinal pathology, whether it be spinal sepsis, metastases, or an acute compressive disc prolapse in cauda-equina syndrome. But other than those absolute contraindications, it should be used urgently whenever necessary and be used as a workhorse. However, by being so readily available, without significant risk for most, it's enabled this epidemic of patients with plausible cauda-equina syndrome to be considered for MR, with the threat of an average £600,000 payout if you get the diagnosis wrong in the UK on relatively recent figures, with that cost doubling or tripling if we include legal costs. And interestingly, the incidence of people presenting hasn't changed during the COVID epidemic, despite all the worries of going to an emergency department with other people likely to have respiratory illnesses. But the clinical situation is a bit like an inverted pyramid or haystack, as we've heard, with a needle at the bottom. At present, we'll perform MR scans in 6 patients for every one who will directly benefit from emergency surgery, which, had it been delayed, might have led to possible permanent harm. This sort of ratio has been seen in many recent UK studies. You've heard it already. We've seen it in Edinburgh, but here are some figures from Hussain and Spink in Hull. They had 250 patients presenting, 34 of whom had a large disc prolapse, and of those, there was a concordance between clinical signs and the large disc prolapse, leading to emergency surgery in a proportion of 17%. Many more patients are being operated now than, say, 30 years ago, when the investigation of choice was either a myelogram or CT myelogram with significant risks. So our threshold of symptoms required for investigation was much higher. Nick Todd has called our red flags of yesteryear the white flags of surrender. And his point is that we can all easily diagnose late chorda equina syndrome, where the history and signs have become obvious, but this is too late to effect a cure or even useful improvement. So we're moving to softer symptoms and earlier MR in the hope, so far admittedly not proven, that more patients will benefit from operation before they develop the irreversible features that are so disabling, the bladder and bowel incontinence, loss of sexual function, and floppy, insensate feet. However, this makes the assumption that operations will not harm patients, and we reverse the normal assumption that the best management for an acute lumbar disc prolapse is conservative with analgesia, exercise, and time. But these guidelines help clarify how to deal with the more recently included symptom of bilateral sciatica, which has been relatively common in the community. It's recently been shown in a prospective study in Edinburgh looking at all referred patients, not quite published yet, to be an important feature differentiating compressive chorda equina syndrome from the scan-negative chorda equina syndrome, where rather surprisingly, bladder incontinence was not. By adding clinical progression, concomitant motor loss, and sacral nerve root neurological features, we hope to reduce that potential flood or tsunami of patients to the local A&E or the regional spinal surgical unit. But conversely, by having bilateral sciatica as a feature, it makes first-line practitioners feel very vulnerable. When we look at the diagnosis in the other 5 patients who don't have a compressive chorda equina syndrome, the commonest is of a functional neurological disorder, as outlined in Ingrid Huritzau's recent, both retrospective and soon to be published prospective paper on this subject. Panic, catastrophization, and dissociation are all seen much more commonly in this scan-negative group. This has obvious parallels with patients presenting with acute back pain, which has been so successfully triaged using the Kiel back pain assessment tool. Next slide, please. What about the time constraints? What's the probable pathophysiology in acute chorda equina syndrome? The progression of symptoms suggests that there's a gradual loss of function, which leads clinicians to act quickly in the hope of intervening in time. However, from animal models of both spinal cord injury and chorda equina compression, it appears that there's a very short time frame to reverse any injury. Our recent meta-analysis of animal models for chorda equina syndrome, published in Spine last year, shows that if the pressure in the spinal canal reaches mean arterial blood pressure, irreversible ischemic neurological injury can only be avoided by decompression within 60 to 100 minutes, a very short time. And we know from the work of Takahashi in Japan that humans with chorda equina syndrome, the interspinal pressures measured at operation are often 150 or 200 plus millimeters of mercury, well over the mean arterial blood pressure. So this explains why recovery in this group can be so bad. Yet, if the pressure doesn't reach arterial pressure, then recovery can be expected and will be good. What we don't know clinically is when the onset of that high pressure starts. It's most likely to be when patients get that awful burning root pain or numbness, particularly when it's bilateral, and even more so when there's demonstrable motor loss in L5 and S1 dermatomes. Hence the emphasis on progression of symptoms in these guidelines. Next slide, please. So to conclude, the key to dealing with patients safely is to have pathways that allow quick and efficient referral into local MR, then on to regional spinal surgical on-call services for the relatively few who need timely operation. As Dan has just said, think about all these questions now, so that if and when the next patient with possible chorda equina syndrome comes in, you'll be able to deal with them easily. Know who to call, how to deal with an unsatisfactory conversation or response. Document everything carefully, particularly when you consider that you do not need to consider an urgent MR scan. Because a bad outcome is so devastating for the patient, it's not surprising that they look to legal redress. Every decision will be mulled over with every comma interpreted by a potentially hostile barrister. Make sure the pathway is complete. Patients get both the scan they need and the next step, including immediate action and follow-up. This part of the pathway has previously been dealt with by staff at the regional spinal surgical unit, where patients had to go to get the MR scan. But with more local MRs being done, the pathways need to be tight enough to prevent the catastrophe of having a positive scan, but not an urgent referral immediately afterwards. So let's do, as Elaine has suggested, join up all these pathways of Cauda-Equina syndrome so that we avoid these pitfalls and we make progress to protect patients. Thanks very much.
Thanks, Patrick. That was very useful, a good insight into anatomy. I think because we've got about half an hour left, so I think it'd be useful because there are quite a few questions on the question answer panel and we've got a very good panel. So I think we'll just move on to questions. Patrick, if you don't mind, please, and get everybody on board. So Dermot, do you want to introduce the panel, please?
Yeah, so on the panel, all the speakers are available to answer questions, as well as myself and Neil. Also, in addition to the panel is Michelle Golden. Michelle, would you like to introduce yourself?
Yeah, hi. Thank you very much, Dermot, for inviting me. I'm the Deputy Director of Safety and Learning at NHS Resolution, so the people Patrick has just spoken to that have the lawyers that will defend the cases. My job is to help organisations learn from these sorts of catastrophic errors so that we can prevent them happening in the future. And my background is I'm a palliative care nurse, still doing a tiny bit of practicing.
Okay, so before we go to questions, I just wanted to remind everybody that we'll be keen to have your feedback from this evening. You will be sent a Google form link at the end of the meeting and a reminder tomorrow. If you need this for your CPD, you will get that. But also we are opening up feedback on the framework. That will be attached to the Google form link on the feedback of the webinar, but then it will be placed on the UKSSB website. It'll be available for comment until August the 14th, so a month's time. So on that, I'm just going to pass back to Sachin and let's see if we can answer some of those questions.
Sachin, are you on mute?
Have we lost Sachin?
Okay, fine. I'll put the question to the panel. I'll club two questions together from Hannah Jones about any guidance on the diagnosis and managing potentially slower progressive onset of CES in the older population. And later on, she goes on to ask, when do you push for an MRI scan in the older patient who has a potentially slowly progressive chronic Cauda-Equina type of presentation? Sachin, are you back online?
He seems quiet there. Patrick, did you want to answer that question?
So, yeah.
I think that's a very different pathology. I've talked about how acute disc-related Cauda-Equina syndrome is a high pressure state. In elderly people with thickening ligaments and gradual stenosis, there's all sorts of reasons why they may also have urinary symptoms. And the likelihood of being able to, of them suddenly becoming, getting an irreversible state is very small indeed. And conversely, the risks of operation can be considerably higher. So that's certainly a trend that we're seeing more and more people with some urinary symptoms and spinal stenosis being as an emergency for consideration of an urgent MR scan. But I don't think that's a very good use of resource. They very rarely have irreversible urinary dysfunction or sacral dysfunction of any sort. And so I don't think they need to be dealt with in the same way.
So can I just follow on that question, Patrick? Do you think an MRI scan report though that goes back to primary care, which says Cauda-Equina compression, please seek urgent neurosurgical opinion, is something that we need to fight against, really?
Well, look at the radiological definitions of Cauda-Equina syndrome. The radiologist is in a very different situation. they mustn't miss it, so they over-report it. So they see an elderly person, and this is a trend that's much more prevalent now. So they see an elderly person with spinal stenosis, and they write a report saying cauda equina syndrome, because by their definitions, more than 50% constriction of the cross-sectional area is cauda equina syndrome radiologically, whereas for us, it's 75% plus, or lack of CSF on an axial view. So they will always over-report it, and we've got to live with that rather than try to change the radiologists not reporting it enough, you know, which is the other end of the coin. So
Right.
I think we have to listen to that and have a way of managing that rather than try to stop the radiologist reporting it, because that could be quite dangerous.
But Patrick, the point is correct. But the other point to make on that is a stenotic and an acute disc are two different pathologies.
Absolutely.
And I think that's the thing to differentiate. A stenotic being called a cauda equina is perhaps not accurate.
Exactly. No, I absolutely agree with you. But we need to respond to that politely and courteously, not get too beaten up about it, I think.
Yeah. But unfortunately, it creates a lot of aggro.
Sure.
Chris, you got a point to make.
Yeah, thanks. I work in an area with a very high elderly population, so this happens all the time.
Mm-hmm.
I was just wanted to point people in the direction of Christine Comer's paper. She did a really nice paper about spinal stenosis and cauda equina in the elderly populations, and looking at other differentials and reasons. So I think just as a resource, it would be an excellent resource to point people towards.
Yeah.
Okay. Rajat, throw it. Next question, please.
Yeah, there's a question from Paul Regan about the document, and this is with regards to bilateral radicular pain, asking about the rationale of getting an MRI scan, whether the document supports an urgent outpatient MRI or a same-day emergency MRI scan.
Okay, I think Elaine should be able to answer that because Elaine presented on the document.
It sounds like that was one of the previous drafts rather than the final document, because in the final document, we took some of those comments out, really because we got feedback around that sort of subject. So the final document is saying for people where they've got bilateral leg pain with some neurology, that they should follow an urgent pathway. Now, that urgent pathway will look different in different localities. In some localities, it may be that the scan is arranged from primary care, and in other localities, it may be that the patient is referred into the hospital and the scanning happens within the hospital unit. But whatever happens, those patients need to follow an urgent pathway rather than the emergency pathway, unless they've got any other features of cauda equina syndrome.
Okay. Rajat, throw it. Next question, please.
Yeah, a question from Suzanne Kennedy. Do you need to objectively test for saddle anesthesia or accept patient's word? I think this goes back to the telephone consultation type of question, I guess.
I think, Chris, you can answer this because you picked up on the telephone consultation.
Yeah, thanks. I think it depends on your environment. If you're doing a telephone consultation, they may describe subjective saddle sensory changes. I would always follow that up with, if the patient's with me, I would test it objectively. If the patient's on the end of the phone, then I would ask them to test it. It's really partly just as a marker as well. So if I'm asking the patient to test themselves, and I would ask them to grade it out of 10 or a percentage. If it's 70% when I'm talking to them and it's 10% when they arrive at A&E, then it might just give us an additional piece of information alongside the rest of the neurological examination.
Now, Chris, going back to something that you picked on in your talk as well, and you talked about checking anal tone, and you said you work through a GP service, but there are some first contact practitioners who don't. Okay, in a GP practice, like Jerry might agree that you may have a chaperone available, like Elaine mentioned it, but there are some setups where you won't have a chaperone available. So how would you rely on that?
No chaperone, no test.
Michelle Goulding, what do you think?
Sorry, I couldn't get to my unmute button quickly enough. I absolutely agree with Chris. If you haven't got a chaperone, don't do an intimate examination. That's simple.
I think most of the panel would agree with that comment, isn't it? That if there's no chaperone, you shouldn't test. And then you just rely on the subjective indicators to give you an idea that this potentially is the case, and you move on. I think that's completely appropriate. Yeah.
Yeah, great.
Right, Rajat, any questions?
Yeah. So the next one is from Oliver Richards. This is to Chris about having mentioned the entire study, which shows 60% patients are referred without MRI. And the question is, will the pathway mirror GIRFT and not mention referral to spine services without an MRI scan having been performed?
Is that directed to Chris?
Yes.
It doesn't at the moment, but I think that would be good practice. And the pathway does mention that patients need urgent MRI scan to confirm diagnosis. So they should have a confirmed diagnosis really before they're put in front of a surgeon, I would suggest. I don't know if Elaine would like to comment on that, or Neil's got his hand up. Sorry, Neil.
I think in all practicality, we have to work in reality and not with ideals. So that has to be part of your local pathway. If you have district general hospitals that are scanning 24/7, you're A, lucky, and B, not typical of the UK at the moment. So at the end of the day, the patient comes first, and if there has to be a discussion, but it's very much as Patrick said, there needs to be something in place to answer that question. What are you going to do with that patient at 8 o'clock in the evening that needs a scan? Well, that needs to be worked through. And if it means a transfer for the time being, so be it. If you can work to get local scanning facilities more available, then that's great.
Okay, thank you. Rajat, Rohit, next question, please.
Yeah, next is from Suraj Bafna. If the patient has saddle anesthesia with back pain and radicular pain, but has been cleared from A&E for CES without an MRI scan, what would be the plan for a primary care clinician? So the patient is sent back to the primary care clinician after an examination without a scan.
Okay, I think I'll involve Jerry in that from his GP background. So the patient's had a scan with suspected cauda equina, MRI is negative.
Sorry, no.
And the patient lands in your clinic.
Session scan has not been done. So the
scan's not been done. I thought scan was done.
The patient presented as a cauda equina, as saddle anesthesia, back pain and radicular pain, but was cleared by A&E with a clinical examination without an MRI scan.
Oh, I think that would be a difficult. I think Dan needs to answer this then. Sorry, Jerry.
Okay.
I was wondering if that might come to me. So this is a really interesting question, I think, and it highlights perhaps the unsatisfactory nature of the front door of A&E being the default for a rule-out cauda equina. So when you send a patient in to ED without them being accepted by a specialty team for review, what you're really doing is just putting them in the queue to be seen by whichever junior trainee next picks up their cards. And of course, we do have safeguards and senior review in emergency medicine, but that varies hugely from centre to centre. And if that clinician who picks up that card, assesses the patient and uses all of their expertise and gestalts to come to a clinical decision whereby they don't think out of hours MR imaging is justified, it seems to me again to be unsatisfactory to then send that patient back to A&E to see another clinician to hopefully get a second opinion. And there needs to be a better pathway, doesn't there? In answer to what would actually be done should that happen, there's a variety of suggestions. If you as a community practitioner have a high enough suspicion of cauda equina syndrome that you think the wrong decision has been made, then I would suggest that's for you to pick up and try and facilitate that scan in daylight hours as quickly as possible. And there's a variety of channels for that. One is to speak to your local spinal team or your radiologist directly. The next is to pick up the phone to the A&E consultant in the relevant department and say, I'm a bit worried that this patient was discharged without being imaged. Can I get a second opinion from a more senior doctor, or can you put me in touch with who I should speak to? And there's a variety of ways to escalate the process, but the crux of it is, when someone is sent to ED to rule out cauda equina, they are seen by an individual clinician who makes a decision at the time. And a lot of these red flags are subjective and they will change, or patients will report different histories, or clinicians perhaps will take variable levels of history depending on how tired and how busy they are. And ED is not the catch-all for this system, unfortunately. It needs to be managed in a more appropriate fashion.
Okay, thanks, Dan. Rajat, Rohit, another one?
Yeah, so I'm going to combine the questions from Kay Stevenson and Clay Paling, and this is directed towards Chris and some of the work done by Michelle. This is around sensory testing. So the first bit from Kay says, Chris, can you share the reference on sensory testing that you mentioned? And he also appreciates all the great session. Claire's mentioned about Michelle's work regarding perianal sensation testing is worth doing. Interested to know, is it more sensitive than we previously thought?
You want me to answer?
Do please, yeah.
So it was a poster that we presented at SBPR, which are in the Journal of Orthopaedic Proceedings, I think. Elaine, correct me if I'm wrong. So the abstract is in there. The paper, hopefully, we are close to submitting relatively soon. But yeah, we found that both subjective and objective perianal sensory testing was predictive. We looked at 1,000 patients that had an MR scan for query cauda equina, of which there were, we looked at the positives versus the negatives and tried to find the positive predictive value. Nothing became, a bit like Laura Fanuca's paper, nothing was nothing was stand out, but one of the things that we found were very important was both subjective and objective perianal sensation that the patient left with the patient.
Michelle, this is another add-on question from Claire, if you may answer, please, saying if we were to test this and if the patient's reporting penile or labial numbness, should we test these areas as well?
We didn't look at that in that much detail, and certainly I don't test that. I don't know about the other physios on the call.
Anyone from the panel? Any views, please?
We don't test it, but we would ask patient to report it, and patient might volunteer that once we'd framed the questions around saddle sensation and sexual function.
Sorry, it's Michelle Golden here. Can I just quickly come in with, I think whether you test or you don't, documenting what you've done and why you haven't done what you haven't done is absolutely crucial, so that when people are going back looking over it, they understand why things were and weren't done.
I think, Michelle, you make a very good point. Documentation of what is done and what is not being done is critical. And even for anything like, a delay in getting a scan, whatever the reason, as long as it's documented appropriately, like that's what we get told about. And I think you're reiterating a very, very important point. Elaine, I think you had a comment and Neil had a comment as well.
Yeah, it was just to say that it depends on the environment that you work in and also your level of skill. So if you're in an environment where that information is going to change the management of your patient, then it's important that you do everything that you're capable of doing. But for the majority of people in primary care, which the pathway is really designed for, they're not going to have that skill level to be confident in the testing, but also be confident with the clinical reasoning. So if the patients flag these things up, then likely it's feeding into that whole scenario where the patient would be referred on.
Okay. Neil?
I was just going to say that anecdotally, I think genital numbness is even more specific than perianal numbness in our experience. But again, whether you test it or not, I think depends very much you have to be in the right environment for that. And I would just go on the history, I think, most of the time.
Okay. Right, Rajat, Rohit, any other questions? Oh, sorry, Patrick, you've got a point. Sorry.
An important point, because I was in a very unpleasant criminal case where these tests were scrutinized. As a clinician, you have a duty to explain and offer a test to a patient, explaining why you're going to do it. So if your test is not going to make any difference, so for instance, you say, oh, I've got perianal numbness and it came on at 6 o'clock this morning, I've had it for 6 hours, who is not going to get an urgent MR scan on that patient? So it's quite difficult if you were then taken to court to say, oh yes, I did this fancy examination because I believed it was in the patient's best interest. So the very least you can do is explain why you need to do it, because many of us believe, although I'm not sure the evidence is good enough, that perianal sensory testing is worthwhile. But at least you believe it and you're explaining why you're doing it. I mean, I think if somebody really scrutinized it hard in court, it would be quite difficult to explain that it was justified. but I think most of us would tend to believe it is, because it's a sensible thing to test sacral sensory function in a condition where sacral nerves are being squashed. But it's explaining why you're doing the test to the patient before and getting their consent that's so important.
Okay, thank you. Rajat, Rohit?
Yeah, so there's some concern being expressed by Julia Tabra, and there's a similar type of question from Burj Kishmishian about the 4-week figure. So the mention of 4 weeks on the framework, not aware of any evidence to support this number, and I've had several cauda patients with 4 weeks of symptoms who needed same-day surgery. And I wonder if it might be better to say symptom onset or progression is within the recent days or weeks. Any comments on this 4-week threshold?
Dermot, do you want to field that question? You're on mute. Dermot, you're on mute. Yeah.
Actually, I'm going to pass that over to Elaine or Chris.
Okay. Go on, Elaine.
That was really nasty.
Sorry.
So the document's really been developed with a lot of feedback from a lot of different sort of arenas. And there is a big difference between someone who has just developed some cauda equina signs and symptoms within the last few hours, the last few days, the last week, and people who have got a very progressive deteriorating pattern. But people who have had symptoms for a much longer period of time and their symptoms are stable, then often it's not that these things are not important, but the probability of them becoming an emergency and requiring surgery as an immediate thing is less. So again, it depends on what your setup is locally. And I think if you don't feel confident in making that call, what you need to do is involve your spinal team to actually ask them what should be happening with that patient. But someone who's had the symptoms for 4 weeks or longer and the symptoms are stable are less likely to be emergency, but are definitely urgent.
But I think, Elaine, that goes back to Michelle's point about documentation. And if that's appropriately documented, then at least, I'm not saying it clears you of everything, but at least it shows that we've thought about it and we managed it appropriately. And I think that's very, very important.
I think that's about managing the resources as well. So we're saying about, do these patients need to be in the scanner that day? No, they don't. But do they need a scan? Yes, they do. They need that
they need a scan quickly.
So they need an urgent scan, but they don't need an emergency scan. So I think but I think it is all in that documentation, as you say. It's about being clear, as Michelle said, about why you've made the decision you've made.
I think as well, often if you are having a justified decision, it could be some years down the line. You won't remember why you did what you did or why you didn't do what you didn't do some years down the line. So just write it down.
I think there's some point there as well in the urgency that if things change, if the symptoms change, if they've had 4 weeks and it's fairly stable, but the patient needs to be aware of how important it is to seek care immediately if things change. And that must be documented as well, because I think an awful lot of people will put just down safety netted, but won't actually state that the patient was advised the importance of seeking emergency care under these conditions.
You also need to make sure that the patient understands what to do if the symptoms deteriorate. So just giving a warning card is not sufficient. You've really got to make sure that that person understands what they're potentially dealing with and what they need to do, where they need to go, should the symptoms change.
Yeah. Agreed. No, that's very helpful. Now, we're coming to 9:30, but we've still got quite a few questions and we've got still about 160 people online. So if everybody's happy, we might just carry on for a few more minutes if that's okay, because I think there's quite a good few questions on the panel. Rohit, Rajat, what's up next, please?
So the next one is directed at Patrick. This is from Leanne Wood. Patrick, you mentioned about pre-void bladder scan of greater than 400 mils. Is this something you would rely on irrespective if they can empty beyond 200 mils?
Post void more than 200, I think, is a pretty good and predictable test, but there's not, and it's got better specificity and sensitivity than many of the clinical tests. But nevertheless, I think you have to put all these things in perspective. And so it's just one of the whole picture, one test in the whole picture. But I think Mike Grevitt's study from Nottingham is the most useful study in saying what's the cutoff point, and it's a pre-void of more than 400 and a post-void of more than 200, and more than 200 because that's in bladder scanning terms, that's the sort of volume that's defined as bladder dysfunction. So it's a useful cutoff point.
Okay, thanks. Rohit?
So
Right.
can I just club two questions together? One is Karen Koppen and Purna Virappa. This is about clinical signs. So Karen's question is, how often does cauda-equina syndrome develop with just back pain alone and no leg pain? And the question by Purna Virappa is, what is the panel's view on the absence of bilateral ankle reflex raising a strong suspicion of CES?
Jerry or Dan, you've not said anything. Can either of you want to take this question, or?
I mean, I can, I suppose, talk a little bit about bilateral absent ankle jerks. Michelle and I are in the final stages of drafting a paper at the moment where I think that is suggestive. But as Patrick said earlier, I think any isolated feature needs to be taken in context because often you get more from the subjective history, I find, than clinical examination. You know, the other members of the panel will speak for their experience, but I usually know whether I'm going to push for an MR scan by the end of the history, and the examination is usually confirming. It very rarely changes my mind. So I would caution reliance on any particular individual clinical finding.
Okay.
Okay, Grant Syme says, any advice on the patient that presents late, 3 to 4 weeks down the line, with cauda-equina syndrome symptoms that have been missed or described as stable or even improving, and there is a tendency for some to advocate an urgent response rather than an emergency. So what do we do with these late presentations?
Jerry, what would you do in the primary care setting in GP land?
Well, I think at that point, you would be seeking consultant advice from a specialist. And you would be, depending on the presentation, but I think you would be looking at same day assessment if you possibly could from a spinal specialist, if that was at all possible. And you'd want a very sensitive discussion with them beforehand to ensure that they knew that this was what the pattern was and where the delays potentially had arisen, whether it was, as someone was saying earlier, that the patient wasn't aware that what we meant by red flags or areas of concern they had misinterpreted or were unaware, and they themselves were sitting on an issue, or whether there's been some delay elsewhere in the system. But yeah, I think my first advice would be to, well, back to document everything, but yeah, to speak to a local specialist in spinal surgery if that was at all possible.
No, I agree, Jerry, because unfortunately, from a litigation point of view, I'm sure Michelle, Patrick, and Neil, what they see on the other end of the spectrum is such a hot potato that, you know, if in doubt, get it looked at. You know, I think, yes, it's easy to say stable, changing symptoms, but I agree. You can't risk something like that because it has got a devastating effect and the outcomes can be quite bad. So I think it's got to be actioned at the right time. Rohit?
So there's...
Sorry, Rajan.
I'll just ask two questions. One is from Alison Renfrew. Could you post the name of the author of the stenosis and bladder paper, please? Thank you. And I hope you can address this, Henry, at some stage, if it can be sent out to you. And the other one is how, from Annabelle Di Salvo, how are you asking patients to self-assess saddle sensations practically?
Chris, do you want to take that, please?
Yeah, it's nothing very clever. I'd normally ask them just to, if they're happy to touch themselves around their back passage, around their genitals. Most people have done that at some time in their life.
Neil, could you add on to that, please? You're on mute, Neil.
And I think that's not unreasonable. The other thing is just to ask them, you know, that when they last wiped their bottom, if they could feel the toilet paper normally.
Fair. Okay.
So,
Rohit?
yeah, so 2 questions. So this is from Sue King and Jonathan Gill. So it's all about timing in terms of how do you define the difference between an urgent and an emergency scan, i.e. same day. So Jonathan is saying, what would you suggest a time frame for an urgent scan in an ideal world? And Sue King says, well, in their area, an urgent scan can take up to 6 weeks.
Patrick, do you want to take that, please?
I think of an emergency scan as within the next available slot for MR, and an urgent scan as the next day.
Michelle, would you endorse Patrick's view from a resolution point of view?
Michelle Golden rather than Angus.
No, yeah, Michelle, sorry. For me, you're on the panel. Michelle helping me. The other Michelle.
Michelle, okay.
Go on, no, Michelle Golden, please.
Oh,
from a resolution point of view.
Sorry. Well, I think, again, I'm going to come back from a resolution point of view and say, if you are able to explain why you've made the decision that you've made, and you've documented why you've made the decision that you've made, and if you're unable to get a scan because the scan isn't available because of no fault of yours, then I'm always going to say from a resolution point of view, document it, explain why you've done it. The sooner we get somebody scanned, the better. Because the sooner you get somebody scanned, the better you can decide whether or not you need to carry out surgery and what treatment they need. And actually, the more we push for scans, the more likely they are to happen.
Okay. Elaine, I think you had a point.
It's about knowing your local pathway for scanning as well, because it's one of the concerns I have about sometimes when they're done by a primary care clinician, because it's not about just when the scan's done, it's when the action can be taken from the scan findings. So if your pathway for scanning is that it goes into a specialist service, they get the scan done, it might be the next day or the day after that, but they can go down to radiology and really push for that because they're often in the local environment and you can actually influence when it's done. In a specialist centre, or if you're a spinal clinician, you can actually look at the scan when it's done within half an hour of it actually being there, and you can take action if you see something that's concerning. Whereas when it's done in an environment, often in primary care, where people are less familiar with the interpretation of the images without a report, it can really delay that person going to treatment. And that's why to me, it's not about the same day, the next day. It's not about who arranges the scan. It's about what is your local pathway to get that person scanned and treated as quickly as possible.
That's great. Thank you. Rajat?
Yeah, again, we go back to the older patient, Chandrasekhar Deka. If MRI mentions need urgent review by neurosurgeon with diagnosis of CES in 75-year-old with spinal stenosis, how should a FCP manage that? Are we safe to manage that in primary care, or should we refer to secondary care? And I think it's the same point that I was making, that when the primary care physician gets the MRI scan report in a 75-year-old, where the report by a consultant radiologist says needs to be seen by a neurosurgeon, what do you do?
I think that's the point which is quite difficult, isn't it? I think Chris wants to answer this. Go on, Chris.
Yeah, I was just going to say it's a really common thing, and as I said before, and I think as clinicians, whether you're in primary or secondary care, you've had the advantage of seeing the patient and the scan. As Patrick said earlier, the radiologist is looking at a picture and is reporting on what they see. We have the advantage of having seen the patient, so if there is cauda equina compression on the scan, but the patient has no other symptoms of cauda equina syndrome, then we wouldn't refer on, and we would we would document that very clearly in the notes as to why we've taken that course of action.
Chris, I completely endorse that view, and I think that's perhaps that's what the radiologist should be stating, isn't it? That there is significant compression, and please correlate clinically. I think that's the answer, and that's what we want. You have to rely on your clinical acumen, your assessment, and the documentation. Unfortunately, that documentation of the report just sets everything off and makes it quite difficult. I think it's nearly 9:40 now, so I think we'll start wrapping up. I know there are lots of questions that I'm really apologies that we can't answer all of them. So what I might do is ask our panelists to give final messages. So Elaine, can I start off with you, please? Can I just some couple of points of take-home messages, please?
And my thoughts are to take this.
Sorry, 1 second. So, Rohit?
Sachin, sorry to interrupt, but because we've got about 10 questions, what I would suggest is that we should note these questions down and then get in touch with these individuals and then answer their questions. I think that will be really helpful because they're very relevant to this and there are 10 questions left. So we will get back to you with all the answers.
No, Rohit, that's a good point. Thank you. Thanks very much. Yes.
Sorry to interrupt.
No, thanks, Rohit. Right, Elaine, please.
So my thoughts are to take this new framework, to discuss it within your local networks and actually look at how this can be used to improve the pathway for people who are presenting with signs and symptoms of Cauda equina syndrome.
Okay. Chris, you were up next speaking, so can I have your final pearls of wisdom, please?
Thanks, Sachin. I'd agree with Elaine. I think if I'm here with an FCP hat on, and I think with the emerging FCP workforce, this is going to play a really key part in how we manage Cauda equina. So I'd encourage the national FCP framework and network to use this framework to help both clinicians and patients.
Thank you. Jerry, please.
Thank you very much for the invitation. I look forward to seeing the final document and we'd be delighted to make sure it's well represented in CKS.
Yeah, I know we look forward to getting nice endorsement. That'll be good for us. That'll be great. That'll go a long way in a way. Right. Dan, you're up next, please.
Just to briefly reiterate the point that I made and I think Patrick made in the presentation following, that this situation is entirely predictable. We will all see patients within the next couple of weeks and think that they might have Cauda equina, and so I would urge you all to use this pathway to springboard local discussions to try and facilitate the best streamlined diagnostic pathways for your patients.
No, thank you. That's Patrick, please.
You stole the words from my mouth. It's thinking about it now, and I think this framework gives us the opportunity to do that. So let's meet up locally to make sure that we've got a framework that works and that we don't miss patients with the awful consequences.
I think that's a very important point, not to miss any patients, and we just offer the best possible. Dermot, Neil, you guys have put a lot of work into this, so any final points from both of you, please?
I'll step in there. I just want to thank everybody for the contribution in developing the framework. It's taken some time, and there's been a lot of people behind the scenes that have driven this forward. And I'd just like to thank everybody and the contributors tonight, giving up their free time on a Wednesday night to help the management of Cauda equina, because it is a serious condition that we need to get better at, and I think we all know that, or we wouldn't be giving this time up. I do reiterate what everybody else said. This is a framework for you to use as a platform to create a discussion locally. We would like you to use the network, the National Back Pain Clinical Network. There's a local regional rep who should be able to help you. There's regional spinal networks who have spinal leads who will be more than interested in helping you develop an appropriate pathway for these patients who may have serious conditions. So it is a case of, this is not the solution, this is just the starting point for you to create those relationships. So on a Friday afternoon, rather than saying, what do I do? You know what to do, who to call, and how to do best by that patient and by yourself.
Neil, before I come to you, can I just add one more point to that? Is that I think if it's not from the patient point of view, I think which is what you should be looking at, but it's the burden on the NHS. So from the ongoing care, because it causes such devastating morbidity to it. Michelle, I didn't ask for your final point. Sorry, Michelle, please, can you give us some final messages, please?
Yeah, you'll all be really shocked to know that my final message is document, document, document. Explain your rationale for the decisions you've made and the rationale for the things you're not doing, and document them for two reasons. One, so you've got a decent record when you need to look at it. Two, because if you are ever asked to explain why you've made your decision making, it will be years down the line.
No, Michelle, thank you. That's very helpful. Neil, sorry, your turn now.
Everything that had said and everyone else has said, I echo. Use the framework, work out your pathways to benefit not only the patient but also your efficiency of local services. This can turn into a major logistical problem at times, and it's good to have a pathway that doesn't waste resources, whilst at the same time making sure that we do our best not to let any patients fall through the net.
No, Neil, thank you. So at this point, a couple of things I would like to mention that Henry's just put a thing on the chat that he'll be able to get the questions to us, and we'll answer those questions and communicate with you guys directly. So apologies, I can still see there are about 17 odd questions on the panel. We will cover those. Thanks to the full team, from the Back Pain Network, UKSSP, BAS, and all the invited speakers, Jerry, Michelle, thank you. It's been wonderful. It's all the hard work that you guys have put in to put this framework together, and I think it'll be very helpful and useful for our patients, and that's what we need. It streamlines things, it makes things a bit more easier, and gets things moving faster. So thank you very much for joining us, and I'll take your leave now. Good night. Thanks a lot. Bye.
Good night, everyone.